All right. So, Nick, do you want to go ahead and get started?
Yeah, sure. Well, welcome everyone. This is the ACP Long COVID Interest Group meeting. We meet about once a month to learn from leaders in the field and learn from new research and clinical guidelines around long COVID treatment and care. So it's my pleasure today to welcome Dr. Eugene Yang and of course, as always, our host, Dr. Anita Chopra. And with that, I will kick it over to Dr. Chopra to begin.
Thank you so much, Nick. And before I start, I want to actually thank Nick as our amazing coordinator, and he is the one who makes this group happen and works smoothly and puts everything together every month. Thank you very much, Nick. So I want to welcome Dr. Yang. I'm so excited to have Dr. Yang here. He is not only a cardiologist par excellence, but also a mentor to so many students and providers, physicians like us. And I'm so happy to have him here today. Dr. Yang is an international speaker and researcher. He is the medical director of the University of Washington Medicine Eastside Specialty Clinic. Dr. Yang holds the Carl and Renee Behnke Endowed Professorship for Asian Health. His research interests include cholesterol-lowering therapies, coronary artery disease, and cardiovascular risk assessment. He's passionate about cardiovascular risks in minority communities and has done trailblazing, tremendous work in the field. It's an honor to welcome him to the ACP Long COVID Interest Group today and to learn from him. Welcome, Dr. Yang.
Oh, thank you, Anita.
So I want to start off by asking you sort of people are referred to you, patients are referred to you from primary care physicians like myself, internists and family medicine doctors. Often they come with what we feel from our end are POTS-like features. So I wanted for us to, learn from you what exactly is POTS. And I know that sometimes, and actually a lot of times, we emphasize this is POTS, and the answer that we get from our cardiology colleagues is this is not POTS. So can you please tell us about what exactly is POTS and how does it relate to long COVID?
Well, thank you, Anita. So I think the first thing to recognize is that, POTS is a syndrome. So that means that it's comprised of a constellation of different symptoms and features. And so it's really not something that I would say is easily diagnosed. And in fact, unlike something like coronary artery disease, where we can do an angiogram or a CT angiogram and visualize that there's a significant narrowing of an artery, we can easily classify that person as having coronary artery disease. I think the problem is that with something like POTS, it's a very complicated or complex, I think, disorder that affects multiple organ systems and has lots of very non-specific features, right? So, when you think about patients who have long COVID, these patients will complain of palpitations, chest discomfort, fatigue, brain fog, orthostatic intolerance, peripheral neuropathy, abdominal pain. All of those symptoms could just be long COVID type symptoms, but not really have any association with something like POTS. Furthermore, I think that when we think about POTS, there are many different potential phenotypes of POTS that are not always the same. And there's, I would say, a lot of uncertainty in the community about whether certain types of POTS really exist. So does hyperaginergic POTS really exist? Even though we talk about that, many patients will come in to see me who have a history of hypermobility and Ehlers-Danlos and think they have POTS. And so again, it's very difficult to isolate some of the symptoms and really truly diagnose patients with POTS, and we could go into that in more detail. Furthermore, I think a lot of patients will express gastrointestinal symptoms, which is very common. And so, those individuals may have symptoms of irritable bowel syndrome, which can often be a manifestation of patients who also have potential diagnosis of POTS. So I think the answer is that I don't think that we try to dismiss anything that primary care colleagues say. I would say that it's just very difficult to diagnose because of so many overlapping features.
Thank you so much, because this was hugely insightful and enlightening, actually, because as a primary care physician, I would look at tachycardia, postural hypotension, and from my knowledge of POTS, that's the only thing that comes to my mind. But as you pointed out, long COVID patients not only have these fluctuations, but they also have overlapping chronic fatigue, they have brain fog, they have cognitive changes. And this was something very new, what you said about GI symptoms overlapping and causing confusion. So I think it's very important for us to know this, but also for patients to know this, because patients automatically, as they Google their symptoms, they come in and they say, oh, I have POTS. So thank you so much for, and also pointing out about the GI symptoms. This is, something, new that I learned today. So what do we know about the impact of COVID on heart rate and blood pressure fluctuations? Are there any specific patterns of these fluctuations that you see in your practice? And I know that by the time patients reach you, they have already seen the primary care physician, or they may have seen a couple of primary care physicians, and they are, already really struggling and have had these for a while.
Yeah, so I think the key thing in evaluating all patients, like this, are first to take a very good history about the onset of the symptoms. Also look at their comorbidity. So do they have comorbid conditions like irritable bowel syndrome? Do they have a history of autoimmune disease, which is also associated with a higher risk of patients having POTS? So taking a good history is very important. I think secondly is what other medications are they taking? What over-the-counter supplements do they take? Those also influence this, right? So if they're on laxatives, if they're taking centrally acting medications, then you want to know about that. Because, for example, when we do tilt table testing, many of the centrally acting medications affect the fidelity of those tests. So that's really an important thing to also make sure that you're not getting a history of just prescription medications, but also over-the-counter supplements that they also might be taking. So in terms of this question, again, patients who have long COVID, who may experience persistent elevations of their heart rate and tachycardia, palpitations, we definitely see patients who post-COVID, even in probably more in the acute phase, who will have a higher susceptibility to premature beats, premature heartbeats, other arrhythmias. Certainly was found early on during the pandemic. So why they manifest themselves in that way, it's hard to say. And whether it's really unique to COVID is also hard to say, because it is common for post-viral infections to be associated with HOTS. And so many of the same features that are associated with post-viral syndromes, not just COVID, also can unmask or be associated with patients who develop POTS like features or characteristics. So it's very non-specific, I would say, but the reality is thorough evaluation of the patient, checking basic laboratory tests, obviously, like thyroid function tests, metabolic panels are important. but it depends on the individual patient. So in some cases, if there's a concern for arrhythmias, then I will do some form of monitoring, event monitoring, or Holter monitoring, depending upon the frequency of the symptoms. In some cases, we may do echocardiograms, right? So if the patient is post COVID and expresses these symptoms, then, as you know, patients are susceptible to developing myocarditis or myopericarditis or pericarditis in isolation. So I will often obtain an echocardiogram to make sure they don't have evidence of myocardial depression or left ventricular systolic dysfunction as part of the evaluation of the patients. So again, these are very non-specific things. So tachycardia in and of itself, it certainly could be a sign that there's some degree of autonomic dysfunction, right? So regulating heart rate and blood pressure is mediated through the autonomic nervous system. And so we know that POTS is a disorder of the autonomic nervous system. And so if you have some perturbation that's associated with COVID or other post-viral sequela, then you can imagine that elevated heart rate may be mediated by some form of autonomic dysfunction.
Thank you for going over the pathophysiology as well. It was very, very helpful. And from the long COVID clinic perspective, by the time we see these patients, they already have had echoes done. They already have had cardiac workup done most of the times. And something that we see, and again, studies are ongoing, I don't think it's substantiated, but what I see in my practice is that these symptoms, the tachycardia and blood pressure fluctuations, are actually one of the first to get better. So people will have persisting chronic fatigue, people will have persisting brain fog and cognitive changes, but heart rate and blood pressure fluctuations are some of the first symptoms to get better, which is actually very helpful and encouraging for patients. So Dr. Yang, with the next question is, what are the common symptoms of POTS from cardiology perspective that are like red flags for you? And especially in seeing long COVID patients, what do you see as the common symptoms? And I know you've talked about it a little bit, but what are some of the red flags for you?
Yeah, so I think it certainly has a variety of different presentations, but I would say common presentations that are sort of diagnostic of POTS are orthostatic sort of symptoms, right? So patients will complain that with positional changes, like going from lying to sitting or sitting to standing, that they experience lightheadedness and dizziness. I think they commonly report sort of brain fog, inattentiveness, fatigue are common. And then clearly they also complain of palpitations. They frequently complain of shortness of breath and non-cardiac chest pains, I would say. So those are some of the common symptoms that I think we see in patients who have symptoms that might suggest POTS. But one of the key things that I think is important to distinguish POTS from, let's say, neurocardiogenic syncope, such as vasovagal syncope, is I think you mentioned that you do orthostatics on these patients, which we'll talk about. So patients who have POTS don't have orthostatic changes in blood pressure typically. The manifestation of POTS is that they will have a change in their heart rate without a significant drop in their blood pressure or change in their blood pressure. So that's one of the unique things about POTS that can be used to discriminate, I think, between the two.
That is so helpful. And I actually have seen this, Dr. Yang, in my practice, is that we will check their orthostatics, and they are most often orthostatic by pulse rate, not by blood pressure. And actually, a lot of them will end up in the ER multiple times with heart racing, which they attribute to perhaps, am I having a heart attack or am I going into AFib? So There is a physiological response, especially in the acute phase. And then, of course, there are pathological changes. How can we differentiate POTS from other cardiovascular conditions?
Right. So again, I think it requires a good history, right? So if patients complain of pre-syncope or have syncopal episodes, I think I would sort of make sure that I'm really identifying what are the key features, for example, prodromal symptoms, right? So if a patient says that I get up or stand up quickly and I'm experiencing nausea, diaphoresis, those are often more likely to be neurocardiogenic in nature as opposed to POTS. However, the challenge is that, again, it's not easy because, first of all, POTS occurs much more frequently in young women, right? The frequency of POTS of male to female ratio is about 4-to-1. The overall frequency of POTS diagnosis is probably not clear, but the prevalence might be up to 1% of the population in the United States. So I think things that you should think about, and this goes through when we evaluate any patient with syncope, are the demographics of the patient, right? So younger women tend to be more likely to have POTS. If you have a 75-year-old man, I would be more concerned about other causes of syncope and requires a different type of workup or evaluation. So I think history is the most important thing. So if the patient says, I went to the bathroom and, post micturition, I had lightheadedness or dizziness, that's more consistent with a neurocardiogenic syncope, in that case, like a situational syncope. So again, the history is very important. So the context of when these episodes occur is important. And then looking at sort of the prodromal symptoms, also comorbidities. And I think that's what helps you sort of discriminate where you think this might be potentially POTS associated with long COVID versus some other form of autonomic dysfunction, or in some cases, in many cases, it's not going to be POTS. It's going to be neurocardiogenic syncope, which is much more common.
Yeah, this this entire spectrum relating, starting with the sort of postural drop in blood pressure to neurocardiogenic syncope to POTS. I think that's what primary care folks like myself, we just need to keep that in mind. And so, Dr. Yang, now this next question is, I feel, the most important for folks who are seeing people in primary care clinic, our family medicine docs, our internists, and even our pediatricians, is how do you make a diagnosis of POTS? And I know that NASA lean test is, very talked about, and we read about it, especially in the long COVID clinic. How do you make that diagnosis? And if you can also please touch upon the NASA lean test, that would be awesome.
Sorry. So I would say that, there are sort of clinical diagnosis of POTS versus doing testing to try to confirm the diagnosis. So, there's, I would say, some, how should I put it? There are probably some differences of opinion, right, about whether you need to do formalized testing before you initiate some treatment, versus a clinical diagnosis based on the features that the patient presents with. So I think in primary care, and just like in cardiology, if a patient comes in with some sort of orthostatic symptoms, pre-syncope or syncope, then obviously measuring orthostatic vital signs is important. So as I mentioned before, that one of the ways to, potentially, diagnose POTS is to do a standing test where a patient stands in a stationary position for 10 minutes. And if there's an increase in their heart rate by 30 points in somebody who is an adult, and 40 beats in somebody who is younger, like a teenager, then that can be, one of the sort of features that might allow you to have more confidence that the patient might have POTS, right? Because doing tilt table testing is not easy to obtain. We do it at the University of Washington, and I certainly order that test quite a bit. But in some cases, to be honest, I don't do that, right? So if the patient meets sort of these criteria based on change in heart rate and based on these other features that I think are suggestive of that, if they have a history of irritable bowel syndrome, they're a 25-year-old woman, then I think you have a higher pretest probability that they have that. What I will often do is tell them that I think you may have POTS based on these changes in blood pressure, based on your symptoms, based on these features. And then we usually decide, number one, do you want to just do a trial and error approach with behavioral lifestyle modifications and see if that approach works, and then reevaluate the patient. Alternatively, if the patient says, no, I would like to do formal testing, then I will send them to do a tilt table test. I would say that in general, since we have seen such an increase in the patients who have been complaining of with long COVID, these symptoms that might be suggestive of it, the majority of the patients, I would say 80 to 90% of them would rather just try some intervention to see if that helps. It is, I would say, a more uncommon and very small minority of the patients for whom we would do the actual tilt table testing. So if you're in clinic, I think the easiest way to try to come up with a diagnosis is to do orthostatic blood pressure measurements for the patients.
Yes, as a matter of fact, that was my next question. So I think that from what you have talked about, and I think the ideal course for primary care physicians is to start off with orthostatics and suggest supportive measures. And we'll come to the management of POTS as well. But I think that there's a lot of anxiety on the part of patients. And most of the referrals to cardiology in this situation are patient-driven. And there's a request to see the cardiologist, and most of the times the testing is negative. And again, by the time they are seeing us, symptoms are on the road to recovery. Let's talk about Dr. Yang.
Anita, I'm sorry, I forgot to talk about the NASA lean test. I think you wanted me to talk about that. So, I mean, I think that that test is how should I put it? I would say that the test is sort of similar to the 10-minute sort of standing test, because that's what the test requires. But it's sort of like doing a tilt table test, but just not doing a tilt table test, meaning that the expectation is to try and limit fluid intake, sodium intake, withholding medications. Many of the, like I was mentioning earlier with tilt table testing, like antidepressant medications or SSRIs, et cetera. And so, even though it is probably a reasonable test to do, it's not really easy to do, right? So it's just like doing, I would say, a workup for primary aldosteronism, where you need to potentially salt load or have patients in certain positions. They're not very realistic sort of things to do, and really would require an environment where you could actually do that kind of testing, which is really not going to be convenient in a primary care clinic or even in any outpatient clinic. So even though I think it is useful, it's probably not practical.
Yes, I agree with you. And I think, we have some folks from integrative medicine on the call today, and I would love to hear from them also during this conversation. And one thing I just wanted to tell everyone in the audience is, if you have questions, please feel free to put them in the Q&A or in the chat, and we will be happy to take them as well. I want to touch upon management, Dr. Yang, and actually for this, condition, for dysautonomia and long COVID-related dysautonomia, I feel that the management can start in tandem with the diagnosis, the workup, and it can start right at the primary care office. And I wanted to sort of get your advice on the supportive measures that we are doing When do we ask them to add salt? When do we ask them to, what happens if they are already hypertensive and we are struggling to control their blood pressure at the baseline? What are some of the supportive as well as pharmaceutical measures that you suggest? At what point do you add medications like midodrine? If you could talk about that.
Absolutely. So the good news is that this typically affects a younger population. So a majority of them typically don't have hypertension, right? So that's the one positive thing, is that the patients who are susceptible to this tend to be younger women. But of course, there are patients who are going to have hypertension. So I think in fact, for all patients, I try lifestyle behavioral modifications first. So I do not start any of the pharmacologic therapies. I always begin with lifestyle changes. So an accurate history, because many of these patients will tend to be volume depleted. So that's a very common finding in patients who have POTS. So the first thing is to get a sense of what their fluid intake is. And as you probably have witnessed from your own practice, patients tend to have generally hypovolemia, and their intake of fluid tends to be low. So the first thing I do is I recommend that they increase their intake of just water to at least 2 to 3 liters a day, right? So that's the first intervention that I recommend. This issue about sodium and salt intake, so that's a trickier one. So even though some of the guidelines or recommendations might encourage people to consume 8 to 10 grams of salt a day, I tend to not sort of focus on that, even though you could argue that you could give the patient salt tablets. I tend to use a more simplified approach, which is that I encourage people to eat sort of saltier snacks. So even though the sodium content is not very high, like if you eat like nuts, like almonds that are salted, or cashews or pistachios, they don't actually have, if you look at the package inserts, they actually do not have that much sodium. So that helps to reduce potentially the risk of increasing their blood pressure, but it helps to drive their thirst. And so that helps them to consume the 2 to 3 liters of water a day. Have I used sodium salt tablets in some people? Sure. But the first line of treatment is increasing their intravascular volume by increasing their fluid intake, eating saltier snacks that are healthy. So I'm not telling them to eat potato chips. I'm telling them to eat like healthy nuts as a way to drive their thirst. And then I think there are other behavioral things that I encourage. So using compression socks, to prevent venous pooling. Those are easy interventions that you can tell patients to do. And then I often encourage people not to sit or stand in the same place for long periods of time to also prevent the venous pooling. So there's no real, I would say, clear algorithm or protocol for this, because that just doesn't exist. So I will tell patients to sometimes, who are often sitting at an office or at a desk, for hours at a time, that they set their alarm on their phone so that they are encouraged to get up every 20 or 30 minutes to walk around to try to prevent the venous pooling that may predispose these patients to having orthostatic symptoms when they stand up after being in a seated position for long periods of time. So I will try those interventions first. And then what I typically do is I will schedule a follow-up visit with the patient about 6 to 8 weeks later to see whether the patients themselves have really experienced an improvement in their symptoms. And so the lifestyle behavioral changes I will try first. If the patient says, oh, they're better, symptoms are more manageable, then we continue to focus on those behavioral lifestyle changes. And obviously, other things that you can do are really sort of teaching them some exercises to try to help them with doing things like resistance training, leg resistance training, using recumbent exercises like rowing, recumbent bike, things like that are things that I would try first before I would encourage, initiation of pharmacotherapy. I hope that helps.
This is very, very helpful. I think these the practical management techniques, things that people can do at home. That's fantastic. And I really love what you said about resistance training and strengthening the leg muscles, especially, to prevent venous pooling, the salt intake, as well as, pushing fluids a little bit more aggressively than we would normally recommend. So very, very practical considerations. Thank you so much. And I know that we have Dr. Iman Majd on the call today. And Dr. Majd is a family medicine physician, and he is also a dual certified in integrative medicine. He is the director of the Osher Center at the University of Washington. Dr. Majd, would you like to add to this in terms of your integrative medicine practice?
Uh, sure, and thanks for the invitation. I wasn't really intending to speak here. Hi, Dr. Yang, and thanks for the
I am on.
Wonderful explanation. And Anita, as you know that we get a lot of long COVID patients coming to us for treatment in our clinic, especially in the arms of acupuncture. We do a lot of acupuncture, which is dealing with the dysautonomia they have. And there's always the confusion between the POTS and dysautonomia and which one is which one, but majority of these patients are dealing with some sort of dysautonomia. And through acupuncture, the goal is to rebalance the sympathetic and parasympathetic nervous system so they become more functional regarding the lightheadedness and other symptoms that they have. In regards of the what Dr. Yang alluded to, it's that's exactly one of the best approaches that I've seen, that kind of making sure that they have enough intravascular volume, and this intravascular needs to actually now become intracellular. And one of the ways that we do it in integrative medicine, instead of just going straight for salt, which is NaCl, we encourage them to have more of a natural type of salt, like sea salt or pink salt or Himalayan salt. I've had several teenagers that, this is especially in school, it has been difficult for them to push fluids. And as you said, we need salt to kind of make them thirsty so they can actually take more fluids. And in order to do that, it was either taking electrolytes, or I would encourage them to put Himalayan salt under tongue. So they put a kind of like a couple granules of the Himalayan salt or pink salt under tongue. And it not only brings sodium, but it also brings some other minerals with it, like potassium. So it's really good to rebalance the whole minerals in the body, and also enhances the thirst reflex, so it will be easier for them to push fluids in. In regards to activity, individuals who stand a lot, like for example, I stand a lot at work with typing and going around, and calf muscle exercises, calf stretches. If people say, I don't have time to do anything, well, in the standing position, we can do calf stretches. Anything that helps to pump the blood back towards the heart, that would be helpful. So just these couple points to add to what Dr. Yang already mentioned. So yeah, thank you.
Thank you so much. These are very, very helpful supportive treatment techniques. And I really love the fact that, both of you have given us exactly the pathophysiology and what is exactly happening and how are we going to fix it. So thank you for that, Dr. Majd and Dr. Yang. Dr. Yang, my next question is, we often, in the long COVID clinic, we advise people cardiopulmonary rehab. We tell them about, especially if they are short of breath and they are deconditioned, they have poor exercise tolerance in the context of tachycardia, hypotension. And you have spoken about this a little bit about exercise. What is the role of cardiopulmonary rehab? Do you refer patients for that?
Yeah, no, that's a great question. So I would say that the reality is that we probably don't refer enough people for that. You know what I'm saying? And I think that the reality is that we don't have, I think, good access to that in some cases. There are long wait lists to enroll patients in that, just because of the pandemic, one. And two, the the issue is really that will the patients really follow through? And that's been a major challenge, honestly. So because, for example, post cardiac procedure patients, the typical recommendation is that these patients enroll for at least a 12-week program, and typically requires 3 sessions per week. So that's a lengthy program. That being said, when there are patients who have these types of symptoms, we absolutely do refer them. I refer them to these types of programs. Overall, I would say that there's sort of a mixed response. Most patients, I think, not most, but many patients do improve, but there's certainly patients who do not. At least the patients that I've seen have not had significant improvement in their cardiopulmonary status, because as it is true that many of these patients are very deconditioned after they have COVID or some other post-viral illness. But yes, I would say I would encourage them. I think what's missing is that we don't really have a lot of data that shows that this type of intervention really improves the patient's overall functional status. And so there certainly are gaps, and we can sort of talk about where some of the research is going now. So yes, I think it's an important tool. What I don't know is how effective it is, and I think it is difficult to prescribe this because I think there is some resistance from patients because it is a lot of commitment.
Yes, I agree with that, and I think that they're dealing with so many different things, and one of the first things that we advise patients, especially with chronic fatigue, is pacing themselves. And we talk about energy conservation, we talk about not overexerting, about keeping their heart rate below a certain threshold, which is perhaps the threshold where they would crash. And one of the things that I have done in my practice is to refer patients to physical therapy. And by default, they end up sort of getting a modified version of cardiopulmonary rehab, which is very good for them. And, through physical therapy, through some form of breathing exercises and doing cardiac rehab, we do see benefit from this. So at this point, I know Andrew Simon is on call. Andrew is a naturopath who works a lot with long COVID patients. And Andrew, if you have a comment, you are welcome to chime in.
Thank you very much. So my background is in also biofeedback, heart rate variability. So I try to use a lot of the tachycardia type approaches with teaching about, respiratory sinus arrhythmia, trying to get them to, find that factor in there, whether we use it for the purpose of direct heart treatment or we use it as a part of maybe calming the nervous system to get people into improved sleep management strategies, those type of things. I have seen a lot of patients where, we see where I'm trying to play with the use of either SSRIs and how that plays a role in, I know QT prolongation or other heart disturbances that can show up in some of those meds. I've had a lot of patients either, either trying to come off of those things as I try to bring other immunomodulators in, LDN or melatonin, to try to kind of quell some of the neuroinflammation that's taking place. So I guess my question is, thoughts around like what you've seen in terms of patients that are on SSRIs or not on SSRIs as it pertains to POTS or tachycardia type symptoms. And then there was a study out, I think in 2024, January, February, about mitochondrial dysfunction. And all of the, as a naturopath, I use a lot of different tools nutritionally to try to help improve, whether it's B vitamins, cofactors, CoQ10, nutrients to try to feed the body. So I know that a lot of that's still not very large scale study, but what I've seen clinically is when I can get someone to, regulate and use their nervous system, and I get their immune system to kind of improve, I start to see a shift in symptoms, and we see less of these, myocarditis, less symptoms overall. Maybe you can speak to any of those thoughts if you've come across any of the things I've mentioned here.
Yeah, so I mean, I think this is just the challenge in general is really the lack of data, for micronutrients or any other nutrients in general. So I think that is one of the major challenges is just that, there are probably anecdotal reports of some of these things being potentially beneficial in some people, but really trying to do a systematic analysis of, let's say, a certain treatment, such as um, CoQ10, for example. I don't really know, how much benefit we would see, as a comparison. So in the cardiology space, right, there's a lot of literature around CoQ10 supplementation for patients who have statin-associated myalgias, for example. And I would say the data has been very inconsistent. And so, again, I think the challenge is that we have a lack of real data in science. And so a lot of the things that you're doing are great because they're sort of trying to address some of these things. But in many cases, we just don't have the scientific data to tell us whether this intervention is going to be consistently beneficial to patients. So I wish I could give you a better answer, but I can't.
And then as it pertains to POTS, I see it all the time in my field. I haven't really done it a whole lot because I know the data is not solid on this, but the use of like nicotine patches. I have clients telling me that they're using that, and I know that was based off of a case study, that the data is not solid on that. But again, if the difference of people using nicotine in any way, shape, it doesn't seem sustainable to me. It doesn't seem like it's when the patients that have anecdotally tried it, whatever benefits they got for specific to POTS seem to kind of be short-lived, and it doesn't seem sustainable from a methodology. So
Right. I mean, I think, you could see potentially physiologically why using nicotine patches might help in terms of probably increasing sympathetic nervous system stimulation. So I could see how hypothetically it could be beneficial, but I agree that that's not probably a long-term sustainable approach. So we can talk about sort of where we're headed, if that's okay, Anita. So I don't know whether you saw, but there is a study that the NIH recently announced a few months ago for long COVID trials that's specifically trying to evaluate potential treatments for patients who have autonomic dysfunction. So there is a study called the Recover studies, and there's one specifically called Recover Autonomic that is going to test specific treatments. And so I think we do need this kind of systematic approach to try to evaluate these patients. And so that study is, I think, going to be starting soon. And so that study is going to look at two treatments that have been demonstrated to have a benefit potentially in POTS patients. And so one is using immunoglobulin, IVIG, and the second is to test ivabradine as potential treatment. So there might be some optimism around therapeutic approaches.
Thank you so much, Dr. Yang, for mentioning that. And, we are also at the University of Washington, one of the Recover sites. And one of the studies that we are starting is called Energize, which is on post-exertional malaise. Another study that will be hosted by University of Washington is on brain fog. So this is very exciting. All of these sort of arms of Recover are going to yield such important information for patients. And I really appreciate what you talked about as management options for patients with dysautonomia, because these are very practical tips, things that can be done without expensive testing. And, I got some DMs as well. And one of them is from one of our residents who is attending. And Renshirjeet, you can unmute and please ask your question for Dr. Yang.
Hello. Hi, Dr. Yang. Thank you so much for the information you provided today. And my question is, what is your advice for the students and the residents seeing long COVID patients?
Yeah, so I think as a clinician, I think what's very important is that many of these patients are very distressed, right? So they're living with these symptoms that are not getting better, right? So they're complaining of persistent fatigue, shortness of breath, palpitations, dizziness, brain fog. And so the first thing is really to listen to the patient and let them tell you how they're feeling. So I think that's very important. So give the patient the opportunity to talk about their symptoms, right? And then I think the next step is really, if you are, I'm going to relate this specifically to POTS. So if you are concerned that the patient could have long COVID associated POTS, then you need to, again, take a detailed history about their medications over the counter, as well as their prescribed medications. What are their comorbidities? Do they have autoimmune disease, which increases the pretest probability? And so those are the things that are important, at least when you're trying to address whether the patients could have POTS associated with their long COVID syndrome. So I think that's the approach that I take, because many of the patients will come to the clinic, they're tearful, they're very distraught from having lived with symptoms sometimes for months to years, in fact. And so I think we need to be very sensitive, because I think many of these patients feel that they've been dismissed in their clinics where they've been seen and saying, oh, you're fine, there's nothing wrong with you, you've done 500 tests. And I think that's really not the approach that I try to take, because I think that just further causes more anxiety and distress for the patients. So key thing is to listen, and then try to identify whether some of the comorbidities and features that they have might be suggestive of POTS based on your evaluation.
Thank you so much.
This was such a powerful and very important message that you gave, Dr. Yang, because I feel that our students and residents are going to see so many of these patients, because they are stepping out into practical medicine, where they are going to encounter these patients, because there are so many people impacted by long COVID. And this is sort of a very new, sort of unknown territory, for a lot of things. And we don't know everything about this. But you hit the right chord by saying that we need to listen to them and not dismiss their symptoms. I think that's the most important thing for our students to know. And also that their symptoms are real, and to actually understand what are the clusters of symptoms that they are experiencing, and more importantly, what is the pathophysiology behind them. So I think in today's talk, I think there was a very nice sort of connection that you created between the pathophysiology and the symptoms, and then leading on to how are we going to fix it. So this brings us to the end of today's session, and I really appreciate the input from our integrative medicine folks as well. And thank you, Iman and Andrew. Thank you so much, Dr. Yang, for today's session. I learned so much, and I'm sure people on the call felt the same way. And we will sort of walk away from this more confident about taking care of dysautonomia in the primary care clinic. Thank you so very much for today.
You're welcome. Thank you for inviting me.
Over to Nick.
Thanks, everyone. We'll see you next time, and look out for emails from me in the coming weeks for our next session. So thank you so much, and we'll see you next time.
Thank you.